Hi everybody, I'm Laurie Cadden, and we are here on this program number 2 about diabetes. We're going to tell you all you need to know about what I consider, because my dad had diabetes, and one of the most horrific diseases you can have, but managed and get an early diagnosis and working and taking care of yourself, you can be so much better at it. We're going to talk a little bit about that with 2 wonderfully qualified people here to my right. We have Dr. Greg Borowski. He's an endocrinologist with Horizon Medical. We also have Kathy Alfieri, who is a registered dietitian at Moses Taylor Hospital. So thank you both for joining us today. And I'd like if both of you could tell the viewing audience, Doctor, we'll start with you, how your schooling, how long you've been in practice, and your reason, because I think it's always neat. How did you get into the practice of endocrinology? What made you want to do that?
Okay, well, very briefly, I went to Wilkes College locally in Wilkes-Barre, and was in their 6-year program with Hahnemann Medical College, and graduated in 1979. And then went into internal medicine and then endocrinology, and back at Hahnemann. And I started practice in 1984 back in this region, so it's been 32 years, going on 33 years, and I'm board certified, board eligible in diabetes and endocrinology and metabolism.
Very good.
Kathy?
And Kathy?
Well, I am a Marywood graduate, but then I had my residency and some clinical experience out in New York City and New Jersey as well. And actually, my specialty out there was diabetes. I had a lot of juvenile diabetics that were pregnant and renal patients that were diabetics. So that was kind of my home base. That's where I felt comfortable. So I've been a dietitian for 37 years. And I do acute care and individual diet counseling as well. And I was on the speaker bureau for American Heart Association.
And I have to tell you, you have a wonderful New York accent. I don't care how long you're here, you can tell. Where in New York? Where?
NYU Medical Center in New York City.
I love the accent, so keep it. I tell everybody, if you come here with an accent, we'll take it. Just keep it, because it makes you a little different, so I like that. So Dr. Borowski, tell us, the topic is diabetes. Could you please explain what diabetes actually is?
Okay, in very simple terms, without getting too complicated, diabetes primarily is the abnormality of glucose metabolism primarily, but it does roll over into protein and fat metabolism as well. There are several different types of diabetes. The most common one is so-called type 2 diabetes, or what used to be called adult onset diabetes. It primarily is related to sort of an insulin resistance, where you may initially have a lot of insulin in your system, and it just doesn't work effectively in regards to getting glucose into the cells. That's probably makes up maybe 80 to 85% of most types of diabetes. You also have the typical type 1 juvenile type of diabetes, which is actually is secondary to not having enough insulin in your system, primarily due to destruction in some way, shape, or form of the insulin secreting cells, the beta cells of the pancreas. And then you do have other secondary forms of diabetes that could be caused by other hormonal situations, or maybe steroid use, abrupt use of steroids, and which can usually cause it while you're on the steroids. And then you have gestational diabetes, which is associated with pregnancy, basically caused by sort of probably an underlying pre-diabetic state to type 2 diabetes, and then added on to that is your the hormones that are secreted by the placenta. So those are basically kind of the forms of diabetes.
And now, one thing I want to mention, we're seeing in the last 5 years, we've been seeing a large increase in what he's terming as the type 2 diabetics, and actually young people, in teenagers, and 20-year-olds and 30-year-olds. Where actually 20 years ago, you saw it more in the later part of life, 50, 60 year olds and so forth. So we're seeing that increase, and a lot of it is being associated with lack of exercise, taking in too many carbohydrates, being overweight. So it's something that, we have high schools where we have as many as 3 or 4 students that are in high school that have not juvenile diabetes, but the type 2 diabetes, which is much different than it was like 20 years ago. So there's a big increase in that. Don't you agree?
I do.
Doctor, the gestational diabetes, if you're diagnosed with that, obviously during childbirth, are you much more likely to develop any form of diabetes later, or is that just, it really doesn't equate to the
Although there are some rare forms where you can have sort of a partial genetic defect in the mechanism where you might develop type 2 diabetes, most type 2 diabetes is usually associated with people who are already mildly overweight and have insulin resistance, have kind of a pre-diabetic state. And then you add on top of that the placental hormone, which is kind of anti-insulin, and so that drags up the sugars. The biggest thing that we are doing a better job with screening for it earlier in pregnancy, so that we have a chance to control a lot with just dietary control rather than medications, although sometimes we can even just give mild medications like something like metformin or sulfonylureas before actually even going to insulin. Secondly, what I always try to counsel my patients on is once they actually deliver, they need to make a concerted effort, maybe not in the first couple of months, but certainly down the line, they need to look at weight reduction and activity control, because about 60 or 70% of people who have gestational diabetes, if they do not lose that weight or control their activity and weight together, that they have a chance of developing regular type 2 diabetes down the line, where you start off with oral medications and then may graduate to other types of products.
Yeah, I'd like to mention that I work actually for Morrison Healthcare at Moses Taylor Hospital, and one of the things that we developed, because there is so many patients with gestational diabetes, is I developed a guideline sheet so that the patients that have gestational diabetes, they get their teaching on their diet during their pregnancy to keep it under control, but then after they deliver, I go back over with them the guidelines. I talk about when the doctor says it's okay for you to be active, you need to increase your activity. You need to make sure, the first 3 days after they deliver, the blood sugar is actually usually normal or low, but then sometimes it does creep up depending on the person. And we talk about food, we talk about fiber, we talk about vegetables and all the different parameters, and we talk about the incidence of developing diabetes, that you could do something about this now.
Okay, so then the cause of diabetes, we were talking a little bit, obviously, no matter which show we do, weight is always the big culprit, so I know that that's an issue, but what actually causes diabetes?
Well, it is a complicated situation, but in very briefly, years ago we used to think that fat tissue is a sort of an inert organ, didn't really do very much except store fat. But going back probably 15, 20 years ago, we started finding out that fat is a very complex endocrine organ, and probably secretes 10 or 20 different types of products that we already know already. And that's why whenever you even give medication, you also need to make sure you continue to work on trying to get the fat tissue down as much as you possibly can, because there are other hormones that affect things beyond sugar. But basically, something called free fatty acids are secreted in high concentrations out of the fat tissue for the most part. It goes to certain organs of the body, like your muscle and your liver and your brain and a few other organs, and the pancreas, that are responsible for carry on normal storage of glucose and so on. And so there's an increased insulin secretion from the pancreas that is needed in order to carry on the same metabolic processes in these tissues, because there's an insulin resistance there. And these free fatty acids, what it does is it kind of poisons what we call the insulin receptor, and what happens is insulin binds to its receptor on the cell. It carries on a bunch of hormonal changes within the cell, which then there's an appearance of proteins that go to the surface and grab glucose and other proteins and pull it indoors. So that's how glucose gets in. If you poison that mechanism, then you can't carry on the same metabolic process. So therefore you need more insulin, i.e. pancreas has to secrete more insulin, and if it starts to peter out, it gets to a certain point where it can only put out so much. And after that, it starts petering out, and then what ends up happening, then your after meal sugars rise, and then your fasting sugars rise, and that's what really causes the diabetes. And now we're finding out that there are more other diseases beyond what we talk about in terms of sugar, beyond what we talk about in terms of arteriosclerosis, beyond in terms of talk about of hypertension and cholesterol issues. Now we're looking at things like, for instance, there's a lot of information coming across the country for the association with cancers. As you are higher in weight, your risk for developing typical cancers, like in males, prostate cancer, pancreatic cancer, lung cancer, in females, breast cancer, pancreatic cancer, lung cancer, that are higher risk. So, but if your weight is higher and you start losing some of that weight, your risk goes down. And then if you're heavier and you compare that to thinner people, the risks are lower in thinner people. So that's just one factor. Number two, we're looking at something that what is often termed in the medical literature now called NASH, which stands for non-alcoholic, and the buzzword is steatohepatitis, which it's a lot of words, and what it really means is when you have a lot of fat in the liver. Everybody's heard a lot about fatty livers. Mm-hmm. And when that happens, there can be a lot of inflammation, and about 5 or 10% of people who have fatty liver can actually develop scarring in the liver, and that can lead to cirrhosis of the liver. So for years, we found out they developed cirrhosis of the liver. We didn't know why. They weren't alcoholics. They didn't have a disease that destroyed the liver. They weren't taking any toxic drugs, but yet they still had cirrhosis of the liver. And it turns out a lot of these people had fatty liver. And finally, for every pound that you reduce yourself in weight reduction, it takes off about 3 to 4 pounds per square inch of pressure off your joints. So you're looking at things like your back, your hips, your knees, your ankles. So it has a significant impact. So you can even basically just say, hey, let's forget about diabetes for a second, and let's talk about the other impact that weight has on these other issues, which affects everybody. Catherine, comment about that?
I agree. It seems like we were actually talking about this before for the setup. We were talking about NASH. And we were discussing that sometimes when you have a person that's a new diabetic and they come to you and you tell them all they need to know, it doesn't always seem to be enough of a reason for them to do anything about it. But as soon as they find out they have fatty liver and they might get cancer from it, oh wow, I need to get to the doctor, I need to get to the dietitian. What do I do? I have to join a gym, and now they're all about that. But I think that should be the other way around. They should be thinking about, how can I keep myself really healthy? So I'm around for my kids or my nieces or nephews, so I feel good, so my brain is clear, that type of thing, getting back to basics.
It's true. But what I think we can clarify too is the difference between type 1, which used to be called juvenile, I guess it still is in some places, and type 2. Does type 2 always lead to type 1? And is type 2 primarily less genetic and more lifestyle, whereas type 1, it doesn't matter what your body size, you're going to get it? And can you be diagnosed right off the bat with 1 as you're an adult versus why they used to call it juvenile, because most people, I'm assuming, got it when they were younger?
Yeah, it used to be classified where if you were under 45, you kind of had type 1 diabetes, and if you were older than 45, you developed type 2 diabetes, which is more the insulin resistance and environmental. But for the most part, when you really look at things, type 2 diabetes is partially genetic. There are actually some genetic syndromes, but it's unusual. But there are a polygenetic inheritance. So for instance, if your mother or father or grandfather had issues with type 2 diabetes, you're more likely to be a setup for that. Now, some of that could be also environmental, if, in terms of, say, the patterns of the way families ate in that time, and a lot of your grandparents went through the Depression, so they carried over a lot of that fact that if you have food, you don't want to waste it, and that type of an item. But basically, when we're looking at type 2, you not only have this setup for type 2 diabetes, but then you also have the environmental issues, which basically is lack of exercise, but predominantly increase in weight. Kathy and I will talk about that in a few minutes about dietary intervention. But when you look at then type 1 diabetes, it's primarily, again, that is more of a classical genetic inheritance, where if you have a brother or sister or parent or a cousin that had type 1 diabetes, there are specific genes that you inherit that put you at risk for developing it. And then usually there's some kind of usually sort of what we call a second hit. It might be a viral infection or something that kind of combines, the virus combines with a certain gene that then sets up the antibody destruction of the islets. And then there is a secondary form. It's what we kind of, it's a bunch of different buzzwords, but some people call it 1A, some people call it 1.5, some people call it type 1B diabetes. And what it is, it looks a lot like type 1, except it doesn't come on abruptly, but you can see over 2 or 3 years, you start putting patients on maybe something, some oral agents or something that's just not doing the trick. And then eventually, within 2-3 years, they really need insulin therapy. And then when you actually check their beta cells for how much insulin they're secreting, it's not much. So, and actually, it's a slow form of sort of a type 1 diabetes. And sometimes that can get confused with type 2 diabetes. But there are ways biochemically to be able to tell the difference between the two. But if you look at it in general, you're looking at type 2 diabetes being somewhat a bunch of little small genes together with environmental changes, and with type 1 diabetes or 1A diabetes kind of being more specifically genetic disease and less environmental change.
So with both of these, I know with diet and exercise, there's a lot of that with type 2. Can type 1, there is no actual cure for type 1 diabetes, is there? Or can it be controlled? What happens with
Yeah, in type 1 diabetes, that's correct. Right now, there's no specific off-the-shelf medicine I can give you that says, yes, we can do that. Now, with that being said, there are certain situations in which we can do pancreatic transplants in people that are more severe, that may need a kidney transplant, or in some patients I've even done specifically pancreatic transplants. They're doing a lot of work, but again, it's still research. It's not a standard of care where they can actually transplant the islets themselves, because it's very complicated, and it takes a lot of money to be able to do it, because you need a large volume of islet cells. And there's no good way of making those very quickly. But there are programs in the country, and they are taking people that will be able to do it. But the bottom line, you still need to be on immunosuppressive medication. But for the most part, those are the only two ways. Now, what has really made big differences, big strides, not only the different types of insulins that are made now, which are more longer acting and less volume and so on, that's made a big difference in terms of diabetes care. But I would say probably one of the biggest factors are insulin pumps over the couple of years that have, they've become more into vogue, and they're easier to use, and they're very simple because everybody uses computers now. It's like using your cell phone in reality. And now probably one of the biggest advancements, in my opinion, in the last 10 years is something called CGMS, or it's called Continuous Glucose Monitoring Device. And actually it's a wireless device that you insert underneath your skin. It has a little filament, 26-gauge filament. And that filament actually will, through a biochemical reaction underneath the skin in the interstitial fluid, in the subcutaneous space, actually will monitor your sugars or check your sugar every 5 minutes. Wow. And that information is then could be transmitted to perhaps the insulin pump if you're wearing one. It does have a receiver that comes with the kit. And also now with the new, some of the new products that are out there, and I won't mention them by name because this is not an advertisement, but you can actually transmit them up to 5 cell phones. And it has a long receiving distance too, sometimes 20, 30, 40 yards. So what makes it nice, if you have a child who has type 1 diabetes, they can wear this. Your mom can be in the stands and say, hey, coach, Johnny's sugar's a little bit low. Can you take him out, give him some glucose, and be on his way? So it has a big far-reaching improvement in control. Plus, if you're an adult, and say you're a businesswoman or business lady, and you're out at a hotel somewhere, and you have type 1 diabetes, well, that information will also be transmitted back to your husband's cell phone. And if your sugar goes low, an alarm goes off, and you can call her, make sure she's okay or he's okay. And you can also tell, if she's not responding, you can also tell the hotel staff to go up and open the door and see what's going on. So you can see how far-reaching this is. Plus, if you have a relative at home that's constantly passing out because of low sugar reactions, then you can be more rest assured that when you look at your phone, you see her sugar is okay or his sugar is okay. You don't have to be calling them up all the time if you're wondering if they don't answer the phone, is something happening. So there's a lot of new advances, and probably these are some of the new things that make the treatment of type 1 diabetes much, much better in 2016 than it was even 10 years ago.
Yeah, I have a few friends who use the insulin pump, not the device you just spoke, but the pump. And they said it has been a life-changing option for them, that their life has never been better. Being a diabetic and a type 1, so one of my friends was 9 years old when he was diagnosed, and he said it was the best thing ever. So little by little, we're getting more and more available.
And if they add the CGMS to the pump,
then that's even better.
It's even better. In fact, a couple different companies, like Google, for instance, are very into medical technology, and they are working on, they call it, quotes, the artificial pancreas, because right now we don't really have what we call a closed loop system. In other words, when the sugar is detected, it doesn't tell the pump, go ahead, give it this much insulin, because we're not quite there yet. But what they're working on is that exact system where they're trying to connect the two together. But the closest we got now is that, every 5 minutes we can look at the sugar. So if it's starting to go down a little bit, starting to go up a little bit, we can tell the pump, hey, let's back off. I'll back off on the insulin rate a little bit, or I'll give a tiny bit more, so you have that function. The other far-reaching thing is that, okay, so you have type 1 diabetes, you go down to your car, you get ready to drive in a car, and you should always check your sugar before you drive the vehicle. Now, before, okay, if you check your sugar 6-7 times a day, you're only getting 6 or 7 points in the entire 24 hours. Well, now you're getting it every 5 minutes. So you just pick up the receiver, look at it, and say, hey, my sugar's pretty good, 94, so I can drive the vehicle without worrying about getting into a car accident.
Does that also monitor, is there a way of keeping track of what that was for to go to your doctor, say, hey, this is what?
Yeah, it is. There's there is what's happening now with some of the units now, they actually are just like you have a cloud device for your cell phones. Well, these things actually automatically now upload to a cloud.
Wow.
And so in the office here, we can have the patient's name with their password into the system. And we can, if they just tell us, hey, listen, I want you to look at my numbers, we can do that. That becomes, for in the medical profession, it's an easy thing, it's a nice thing. It's a lot nicer if there's another connection where you don't have to actually go in and get it out, because it becomes more another step we have to do as healthcare providers amongst all the other stuff we have to do. But a lot of times we just, the patients will bring in their pumps when they come in their visits, and we'll just download it, and we can see all their activity level.
I was thinking, when they come to visit, do they have?
It's automatically downloaded in a PDF file.
So tell me, either one or both, symptoms of diabetes. How would one know that they have, or that they even should be tested, or there's an issue that they're feeling? What are some of the classic symptoms, Kathy?
Well, one of the things usually is weight loss. Sometimes they have a sudden loss of weight. Another thing is some of the patients will have nausea, vomiting, some of those kind of symptoms. So there's a lot, the doctors would check their blood sugars, but when they start having like a significant 10 or 15 pound weight loss in a short period of time, that's one of the things that's tested for. Would you agree?
Yeah, that's very true. It's probably one of the hallmarks, especially in type 1 diabetes. In younger kids, and suddenly in younger kids, actually, one of the things is that they get up and urinate a lot at night. So that what ends up happening is, normally, especially, younger kids usually don't get up and urinate a lot.
Not like us older kids.
Older folks like us might do that. Okay, whether or not we have diabetes or not.
Yeah.
But so a lot of times you see your kids getting up once at night to get a glass of water and to urinate might be okay, but you see the kids getting up like every hour, you got to understand that's not normal.
Right.
And then a sudden weight loss, even if they're exercising a little bit and you look and say, wow, they're really losing a lot of weight, then you really need to look at that and think that there may be something going on. So, and now with the simple finger sticks everywhere, it's an easy thing to do.
And excessive thirst.
Excessive
Yeah,
thirst,
and what
right.
about a rash, like rash on the arms?
Well, more often you see that probably in females. Okay. Because if your sugars go up to 200, 300, 400, you may often get candidiasis in certain areas, especially the vaginal area in females. But even males can get basically what we term jock rash, or whatever. Or in females underneath the breast area can sometimes be areas for rashes or skin infections like abscesses and things of that nature. But most of the time, especially in type 1 diabetes, it's weight loss, getting up at night to urinate, drinking a lot of water, a lot more than what you normally would. But the same thing happens in males, although in adults with type 2 diabetes, it's a little bit more subtle because, number one, the rises can occur over years, and it can be a slow increase as your pancreas slowly gets more stressed and petered out. And then, in addition, your body has a tendency to get a little bit more used to the higher sugars. But a lot of times, in addition to those other symptoms that I mentioned, blurriness of vision, or you go to your doctor and you pay your $500 for your eyeglasses, and then 4 weeks later you're complaining about how incompetent the doctor is because they gave you such poor glasses, and it turns out that your sugar has gone up higher, so you have a lot of blurriness of vision because of the sugar and not because of the refraction. And in fact, really, you should not really get a new refraction until your sugars have been stabilized for at least 6 weeks.
Yeah, and sometimes I think when you go to a doctor, I've had people who have gone to an eye doctor just for their exam where they have said, I think you need to go to your doctor because there's a possibility. I don't know that is true or not, but I'm assuming it is if there's something to do with the eye. Kathy, you're saying yes. I mean, is that...
That is very true, and that's why people should have their eyes checked every year, because the eye doctor can see if there's a tendency, if there's problems. They also can see if there's cholesterol starting to build up in the eye area. It's another thing they can look at. But people complain that, oh, my doctor took all this blood, when I went for a regular visit to see. Well, that's because they are checking every 2 years to see, are you becoming diabetic, even if you're not overweight. It's something that comes on. So your doctor's visits that are preventative are extremely important.
So tell us then, we talked a little bit earlier, you mentioned that you're going to speak about this. The best way to manage diabetes is what?
I think knowledge and education first. You can't stick your head in the sand, and especially in teenagers. There's always a black box between the age of 13 or 14 and 17. They don't really want to tell their friends anything about any medications they might have or diseases they have. But I think the important thing to note to teach your teenager is that everybody has some type of medical problem in most cases. It might be asthma, it might be allergies, it might be gluten sensitive enteropathy. It might be a seizure disorder. So probably everybody has something in some way, shape, or form. So hiding your disease is not a big deal. Sometimes you get a cool nickname out of it. But,
Do you?
But I say if you have good friends. But I think the most important thing though is that it's important to let other some of your closest friends know that you have diabetes. It's like that advertisement on TV about the peanut commercial.
Yeah.
They say that they didn't know that their friends know that they had a peanut allergy, and she ended up cooking cookies with a peanut butter, and the patient had end up having an anaphylactic reaction. So it's the same type of concept. If you have diabetes, you should let your friends know, and if something happens, like you're confused or whatever, to get you some glucose or whatever, something sweet to get you, or at least take it to a medical facility so they can treat you, not to just think that you're just goofing around or you're or whatever. So I think that's important. The second thing, in type 1 diabetes, there's no way around it. You're going to need insulin therapy in some way, shape, or form, whether it's sub-Q insulin therapy, whether it's pump therapy, etc. You're going to need insulin therapy in some way, shape, or form, as well as being not necessarily rigid, but a little structured in regards to the food you're eating and so on. And education, we have a lot of new ways we can put food plans in place. You can take standard insulin shots. You can take with a fixed dose, or you can modify it with counting your carbohydrates. And if you have more carbs for this meal, you get a little bit more insulin. You get less carbs for this meal, you get a little bit less insulin. So those are factors in type 1 diabetes. And then monitoring your sugars are also extremely important. In type 2 diabetes, it comes down to exercise and weight control. And really, Kathy and I might differ a little bit in terms of our dietary approach, but my feeling is that there's really three important things. Number one is I don't really care how you get the weight off, because almost basically every diet is going to encompass low-calorie products. No matter how you want to slice the cake, you have to get your calorie content low to get the weight off. The problem is in some people when the weight is a little bit higher and as you gain a little bit weight, your body does reset the point where it makes it a little harder to get the weight down. Or, you get some of the weight down and then the body starts secreting different hormones to try to maintain the weight. It's kind of an anti-starvation type of complex. But the bottom line is probably the most successful program maybe something like Weight Watchers. That's relatively inexpensive, very good program. The private dietary intervention is very good. It's always good to at least get a couple visits with a dietitian so you have a direction of which way to go. But there's also a lot of other fad diets out there. But basically, counting your calories and making sure you know how many calories you're consuming in a day and where your target has to be in order to get the calorie content down. There are some diets that are very healthy, like the Mediterranean diet. But again, it comes down to portion control for the most part. The problem in the United States, for the most part, is three major things. Number one, we consume too many animal fats across the board. You may not think you consume a lot of animal fats, but we just rotate. Every day we just have a different type of animal fat. Number two is portion control. If you get to a point where you can't eat another bite, last 40% of your food is way over the top. So, and you have to be careful. And you have to be careful with restaurants, too, because restaurants know, whoever's in the food business, they know that every person that walks through the door, you can probably sell them 2 meals. Okay, they creep up the cost of the appetizers, and a lot of times the appetizers themselves, if you get above $10 or $11, are probably enough for a major meal itself. And then number two is then you order a regular a meal, and especially if you're at an Italian restaurant, well, you don't want to waste it, and you don't want to take any food home. So the bottom line is that you consume as much as you can until I can't eat another bite, and then you take the rest of it home, which sits in your refrigerator for a week, and then you throw it out because it grows mold. So you're not only overeating, but you're also probably can save yourself $15 or $20 if you just, pay attention to what you're actually eating, Kathy, why don't you, I've talked enough about dietary.
That's okay. Well, we definitely agree on a couple of areas. We agree on portion control, very important. Counting the calories, but also counting the carbs, because you can eat a balanced 1,600 calorie diet that has the right amount of carbohydrates, and you can eat 1,600 calories that have way too much carbohydrates and not enough protein in the diet. So you do have to be careful and balance. I also feel that exercise is imperative to control. Not only does it help with the weight loss, which we do agree that weight loss is very important, but exercise helps you burn off that glucose that is in your blood system. Also, it's important for people to start early, like with their children, to have their children do exercise and activities with them. Be active with your kids, because kids learn what they see. And exercise activity level is determined in a child by the time they're 11. Not 16 or 17, 11. So if they see you riding a bike and they'll ride a bike with you or behind you, or you take a walk together, you are implanting that exercise can be fun. I don't care if you have to put headphones on them or something to get them to do it, or play music. That should be an important part. Separate fun from food. So if they get an A on their report card, it shouldn't be a piece of cake or going out to a restaurant. Maybe it should be money. I think it should be money. What do you think? I think money should be the reward of a good grade.
The answer to
or
everything.
go to the bookstore and buy a book. Another thing, so start that early, because it does have a big difference. And if you have somebody to walk with, it'll help you want to do it. The other thing that I think is important is how you shop. It's funny because we'll take somebody that's coming back for a second time. I'll say, bring your grocery receipts in. Well, the most expensive items are the fast food and junk food stuff on it. So I'll say, you know what? There wasn't enough fruit and vegetables on this. There's not lean meats. Again, getting away from the animal fats. There was way too much fat. What's this whipped cream? You didn't need whipped cream. You didn't need Doritos, Fritos. I say anything that ends in toes is going to be trouble. Doritos,
I have to
Fritos.
think about that one. Okay.
Another thing that I do is I tell people this all the time. I'll say, look at your hand. Okay? Do you
That should
see
be
in
the
your
meat
hand
size?
that you can see those lines? Okay, so the protein foods you eat, you should be able to see the lines. Can you see the lines in sausage? No. In pepperoni? No. In a can of tuna, if you open it up, guess
can
what?
see
You can
lines.
see lines.
I know.
You can see it in lean ham. You can see it in turkey. So I tell people they bring their hands with them to the grocery store. That should be a good way of deciding on foods that have less fat in them that are protein foods. The other thing I say is people should have legumes and nuts, things like walnuts, seeds like sunflower seeds. Those things are good things that are snacks. They have protein. Drink water with them. They help people feel satisfied. The other thing we agree on is you need to stop before you're full.
Yeah.
If you eat
That's hard, though.
slowly, well, here's the thing. You're eating, okay,
And
your
you're
food is
blabbing
in your
and you're-
esophagus. It hasn't hit your stomach yet.
Exactly.
If you eat slowly
Slowly.
and drink water in between, you're going to consume less food. And if you do vegetables first, and I tell people, if you have like a family member, a husband that just wants to like chow down and give him I give my husband a cup of carrots while he's waiting, while I'm cooking dinner. Here, eat these carrots, here's a glass of ice water, and he eats it. And that's the only way I get him to eat vegetables first. But it works.
Yep. Well, it makes sense. And it is right with the water. I think, but I feel like what you say, in between. So many people drink it while they're waiting. In between the vegetables or eating in general is a good idea.
And how many people never put their fork and knife down while they're eating?
Yeah, that's, yeah.
You need to put it
consciously think of
down,
that,
right. You need to eat slowly. You would eat a lot less extra fat, extra calories by eating slowly. Here's another thing. After everybody's taken their food, why are the extras still on the table? Take them off the table, put it up on the counter.
So it's
So if
not
they
in your
want a
stomach.
second, they got to go
Get
walk
up.
for it. And then I put the food right away. It's in the refrigerator, right? Yeah, it's too late. You want something, have a piece of fruit, have, like, there are little things you can do. Here's another thing, and one of my pet peeves. Look around the kitchen. If you're looking around the kitchen and you can see a whole mess of food out, not a good idea, because guess what? Your subconscious, from all the things, your favorites, you got your A and you had a piece of cake when you were a kid. So your subconscious is looking for food. If it doesn't see it, believe me, out of vision really helps. I tell people, if you have ice cream in your freezer, I don't care if it's light ice cream, it should be behind the frozen vegetables. So when you go in to get
You're not
ice,
looking
you're
at
not
it.
seeing it. You should have raw vegetables cut up and ready in a Ziploc bag in your refrigerator. So if you have something to eat, put it out for kids for after school. Don't let them hunt for the bad food. Have the good food ready.
Or you can leave the lid off the ice cream a little bit and get all that terrible ice, and then you won't want it anyway. That's a waste, as Doctor said though earlier. Now, Kathy, what I need to know is, you just said there's no lines in pepperoni and no lines in sausage. What did you tell me your last name was?
Alfieri.
Okay, that's
I'm Italian.
sacrilege to the Italians.
Well, I had to tell you,
Pepperoni and sausage.
I will.
Or a meatball, for that matter.
For my marinara sauce, because my husband was used to, sausage and so much fat in the marinara sauce that it was orange on top. So what I do
good, though.
is I put the celery seed, the seeds in that are in sausage. I put them in the sauce and more
so it
onions.
tastes like it.
And my husband will hunt with the fork.
Looking
Where's
for the
that piece of sausage? I know it's in there somewhere. I'm like, it is not. It is not,
sorry.
and it's not.
But, and I want to ask one more thing, because it goes back to this, and Doctor, you might be able to answer this one. All of the talk now about all of these bariatric surgeries, and they say for some reason that if somebody who has type 2 diabetes gets, I think it's the gastric bypass one, it eliminates the diabetes. Is that correct?
No.
No? Okay.
And the reason why, let me qualify that. You know what? The bottom line is, no matter how you slice the cake, if you, and we prefer not to slice the
Yeah,
cake.
I know.
But the bottom line is that as soon as you convert to a situation where you are going the other direction, where you are now burning off calories, your body becomes very insulin sensitive very quickly. Plus, if you're not taking in the calories in a short period of time, your sugar levels will drop very quickly. So as soon as you had the bariatric surgery, you go from a regular diet, say, let's just throw out there 2,000 calories, down to basically 500 calories or less. So you're not taking, and in the first 24, 48 hours, you're usually probably more on or even longer than that, you're on more just IV fluids because you're waiting for all your wounds to heal and so on. So the bottom line is, if you look at the long-term statistics, if you look for intestinal bypass, long-term success rate at about 4 years is only about 35%. And it varies, from study to study. And then with gastric banding, it's probably only like 18%. Because, the bottom line is, how much
not
is
foolproof, right?
right? Well, how much
Yeah.
is a shake when you go to McDonald's? It's like, a large shake is probably 1,000 calories. Well, what do you eat a lot when you first start on the meal plan? You're on liquid
Right.
products, although the quantity is very small. But it is very good for a lot of situations. But I think if we start early on, where we're able to employ a lot of the things we've just talked about, that we can maybe never get to that situation, or get to a situation where it's not as bad. I think one of the things that is important, but we rarely use it, and because it's just not available, is behavior modification. Because even if you take people who have either lost weight substantially, like you talk to people, have you ever been on Weight Watchers before? Oh yeah, I lost 40 pounds of that thing. Well, what happened? Well, I kind of went off the meal plan. Well, hello, you went back to your old eating habits. But the same thing. I had a gentleman in here the other day. He had intestinal bypass, and over the last 8 months, he lost 127 pounds. Okay, but he, even though, and he had basically what they call a stomach sleeve, if you will. So they reduce the size of the stomach. When he eats just more than a small amount of food, he does get stomach distension and pain. But he tells me, I definitely have this eating disorder, because when I'll go to a party or whatever, and even though I know I can only have just a little bit of this and a little bit of this and a little bit of this, he said, I'll you look at my plate, it's filled. And it's because I know I want to try to eat this stuff. So it's an eating disorder. So a lot of times what we need to do is we need a behavior modification in addition to that. But technically, does it cure diabetes? Well, yes, it does, because you've lost the weight per se. But it's not like it's a permanent cure. It's if you can be, but if you go back to your old eating habits, it's just your diabetes is gonna come back.
So let's end this on what happens. When you have unmanaged diabetes, what happens to the body? What can happen to the body?
Okay, so acutely from diabetes, all the diabetic complications, potentially blindness, strokes, heart attacks, intestinal problems like having uncontrolled stomach issues with nausea and vomiting, uncontrolled diarrhea, loss of limbs, toes, etc. Then you get into uncontrolled hypertension, dialysis. You get into hyperlipidemia, and then we've already talked about things like, what about the risk of cancer now? What about the risk of cirrhosis of the liver? What about if you're heavier now and you have diabetes and you've got to carry all that weight around for your joints? So you've got all those type of issues as well. So there are so many far-reaching consequences besides just control your diabetes and a lot of the classical damage that we normally have. On the other side of the coin is, if you take good care of yourself, and if you meet your goals in therapy, and I'll just throw out here, an A1C usually is around 7% or less, or 6.5% or less, depending on which society you believe in. But if you reach your goals most of the time, and you try to eat healthy and do the things you're supposed to, check your sugars and so on, and do a little bit of exercise. And an exercise can be just a little bit more than what you're doing now. It doesn't have to mean you have to go down to the gym. Okay? So if you do all those things, people can live a normal, healthy life for a long time. I have a lot of diabetics who I know for years they were not under very good control, got their act together, did a very good job, and they've had diabetes for 50, 60, 70 years.
Wow.
So it's like, and I have a lot of type 1 diabetics who are in that category. So diabetes does not necessarily mean a death sentence, or I'm going to have a stroke or have a heart attack or lose my leg. Okay? It's all in here. And I think the most important thing that people in health in this day and age is that we put a lot of onus on the healthcare providers, and the biggest thing right now is you as a patient has to take responsibility for yourself. You can't blame anybody else but yourself. You can use the healthcare providers to, guide you in terms of what's the best way to get to that goal, but you got to take responsibility for your own health care. And if you don't do that, a lot of times it turns out it's your own fault.
I definitely
Closing
agree.
thoughts, Kathy.
Well, here's the thing. As he said, if you get it under control, but sometimes there is that party you go to, and you might get out of control for that day. So the important thing is to remember, that's only one day. Don't it be the start of, okay, now I'm going to stay out of control for a week or 2 weeks. Get it
back
right
on.
back in the next day. Put that extra activity in. Drink more water. Get things down. I know a lot of patients where they'll say, maybe they're in the hospital with diabetic ketoacidosis, which is when the blood sugar is very high and electrolytes, everything gets out of whack. I tell them, well, what did you do when your blood sugar was 250? Well, I stopped taking it, I stopped eating it. Well, actually, you should have been drinking a lot of water. You should have taken your blood sugar medicine. Take it again in another half an hour. See what it is. If it's climbing up towards 300, you should be calling your doctor and find out what to do next. So in closing, I would say, if you have that one day, that one party, or that one vacation, that day you went to the buffet and you saw everything you wanted and you ate it all, the next day, get back on track.
Yeah.
Make it a point. Don't let it get to the point of needing dialysis or elevated blood pressure and all the other things that go along with it.
Yeah, it's important. And again, I want to thank both of you, because I think so many misconceptions. There's a lot of, I find, shame around telling somebody, like you were saying, tell someone. A lot of times you hear, I don't want anybody to know that. And it isn't. It's a disease. It can be managed, and people are there to help. And if you just pay attention, as you said, it's all about, you have to take ownership. You have to do it. Talk to people who can help you and make the right choices best you can. When you have a down day, get up the next day and do it right? So that's a good takeaway for everybody?
Yep, it is.
Okay,
Thank you for having us.
Thank you. I
Thank you
really
very
appreciate it. Everybody, thank you so much once again for watching. This was the second series this year from Lackawanna County Medical Society's Public Health Education Series on diabetes. Next month we'll be doing with downstairs, Scranton Orthopedic. We'll be right down here. Maybe we'll come back up and see you, Doc.
There you go.
Scranton Orthopedic Specialist. We're going to be talking about foot and ankle care, and it's running time. The marathon's coming up. We're going to talk a little bit about that and how you can take care of yourself in that realm. Down in that's one of the craziest joints down there in the ankle, isn't it? Woo, it takes a lot of wear and tear. So we will see you again. Thank you so much for watching. I'm Laurie Cadden. We'll see you next month.